Club, JPC, with Professor Elhanan Bar-On, Director of the Israel Center for Disaster Medicine and Humanitarian Response at Sheba Hospital, who will speak about cooperation with the Palestinian health system in fighting the coronavirus. I want to thank Yoel Reven of Sheba International and my colleagues at JPC for facilitating this webinar. Professor Bar-On will start with a short introduction, and then we'll open up for Q&A. You are on mute, so please type your questions on chat, and Professor Bar-On will answer them. Sheba Hospital established the Israel Center for Disaster Medicine and Humanitarian Response under Professor Bar-On's direction in 2017. Since then, the hospital has sent cardiac surgeons to Nigeria, doctors to Tanzania and Mongolia, Zambia, and even Papua New Guinea, I believe, providing aid to people. And obviously, when the coronavirus plague erupted, Professor Bar-On and his team turned to our neighbors, the Palestinians. So, Professor Bar-On, please tell us what you have been doing in the recent days.
So let me just start over a month ago, because as head of the center, my team and me, we set up the facility for treatment of corona patients in Sheba. You must realize when we started, although we have a lot of experience in various disaster scenarios, the coronavirus is a very different scenario, both because we don't know the virus and for many other reasons. When we started off, we actually turned to the WHO directives for facilities in the Ebola. That's where we learned the principles from. But since then, in the past month, we've really accumulated a huge amount of knowledge and expertise about how to manage this situation. It's not only about treating patients. Actually, treating patients, I'm not saying it's the simplest part, but it's the part which is most similar to what we do in everyday life, because obviously we and every other medical center is well experienced in treating severe pneumonias and severe cardiac diseases and all the other clinical manifestations of corona. The difference is in the way we manage the facility, the way we manage the patients. It's all about details. There's a lot of details about how we manage this, because the goal is, number one, to prevent the spread of the virus to the environment, and treat the patients, of course, but more than that, which is a bit contrary to our DNA. Usually, our patients are our main concern. In this case, we have two other goals. Number one is to protect the staff from getting infected, because if the staff get infected and you drop in your numbers of staff, so you won't be able to treat the patients. And the other one is, in our specific situation where we set it up in a hospital, is to protect the hospital from getting infected, because we have to remember that we're all focused on corona. But if we save 100 corona patients and we lose 300 patients to heart attacks, diabetic ketoacidosis, or whatever, so we haven't accomplished our deal. This is also important not only because of preserving the hospital and ensuring operational continuity. It's also important on the national level to maintain the confidence of the population in our medical system, because they have to realize that, number one, they can come to the hospital and it is a safe place to come to. One of the problems we had were people delaying their coming to the emergency room with chest pain or other problems because they were afraid of the corona. So we really have to convince them that the hospital is a safe place, and continue treating the patients, and with that, treating the corona. And the way you do that is there are many techniques we made, and starting from choosing the facility, which is remote from the main building of the hospital. And then a lot of other technical things, some SOPs and and a lot of techniques we do in order to protect the staff and protect the patients. This includes use of PPE, personal protective equipment. This includes all kinds of ways we seclude the patients, how we diminish the number of contact, the amount of contact between patients and caregivers, how we, and basically what we did is we tried to upgrade that facility all the time in order to give us the ability to provide a level of care in the facility which prevents the need to transfer a patient into Sheba. Or let's put it this way, our philosophy was bring Sheba to the patient in the facility rather than bring the patient into Sheba. And we really have, except for very, very rare cases, there was one patient who was on ECMO, which is a cardiac support machine, which we could not do, and operations which we have to do. And then again, we also arranged the hospital in a way which will prevent it getting infected. Having said all that, we accumulated all this knowledge, and we felt that it is very important to disseminate this knowledge around us. Sheba, in its DNA, sees lending a hand to people near and far as part of our DNA, and that's why our center exists. But it's not only our center; that's the philosophy of Sheba. And we think we have a global role, definitely with our close neighbors, and also with the faraway places, as Uri mentioned before. When we talk about the Palestinian Authority, so it's not only altruistic, it's also a question of we're all in the same boat in this. This is a regional issue. And if there's a huge outbreak of corona in the West Bank or in Gaza, it will obviously transfer to Israel as well. So we really have to see this as a regional issue.
So tell us a bit about the encounters
it started off, actually, we are working very closely with the civil authority managing the West Bank, with Dalia Bassa, Olga Katz. These are people who are in charge of the connection with the Palestinian on the Ministry of Health level. And initially, when we started off, once we'd accumulated some knowledge, we organized a few sessions where people from the hospitals in Israel, who were still, one phase after us, came, and we shared all our knowledge with them. Of course, it's important to spread this knowledge, so everybody does the best we can do. In that capacity, the civil authority brought a group of medical professionals from Jericho who came, and we explained them, we showed them around, and we explained them exactly how we work and the principles, etc., etc. And then I said to them, why only come here? Why we should come and see how you're setting up? And that was the first encounter where I went with the civil authority. We went to Jericho. We saw their facilities and also gave them a long session of discussion, both telling them and sharing what we know, but also listening to what they need and trying to see how we adapt a lot of the things we did in Sheba, some of them very high tech and not possible to apply in lower income places, but some of them are very simple, low tech techniques which can be applied universally in this. We followed up on this with going to visit several hospitals in East Jerusalem, which includes Makasset Hospital and Augusta Victoria and St. Joseph Hospital in Jerusalem, where we did the same as we did in Jericho. And then we had encounters with groups of health professionals from the Gaza Strip at Erez Crossing, where obviously we can't go in there, but where we shared our experience, our knowledge, answered their questions, involved our experts like Professor Regev, who's head of infection control, who gave them phone consultations on things which are troubling them as they're troubling us.
We just had a webinar about Gaza. Can you tell us more about the situation, the health situation in Gaza, how they are coping?
Well, you have to realize Gaza has two problems. As in disasters in general, the one thing which characterizes disasters, be it an earthquake or a corona outbreak, is an extreme imbalance between the needs and the capability to fill these needs. Gaza has basic, unfortunately, very basic capabilities in the health sector, as in others. And the other problem in Gaza, there are a few problems. One is the population density. I mean, at the moment, they don't have a large number of corona cases. They have known confirmed cases, only 9 cases. There were actually 2 people who came in from Pakistan and were tested positive, and then another 7 of the guards in the quarantine area where they were turned positive as well. But they're well contained now at the moment. The problem in Gaza is the potential for catastrophe is huge because of the huge number of people and the way they live. Paradoxically, their seclusion might be playing for them, you know, for the first time, it's doing something good for them. But the potential of a catastrophe there is very great. And the other given is that they have low capabilities. There's only one lab in Gaza doing tests. They have a great shortage in PPE and protective personal equipment and swabs, and the capability to do all this. However, you know, in all my encounters with these health professionals, these are all very, very professional people. The conversation is very professional. I mean, obviously no politics, no religion or anything like that gets into it. We tell them what we know, we hear what they know, we see how they're this, we give them some advice, some little tips here and larger tips somewhere else. But you know, they also have, we're not the only ones helping them. WHO is active there, MSF is active there. There's an American group building a field hospital in the northern part. MSF are building a field hospital in the southern part. They themselves have set up some quarantine areas and are setting up their hospitals according to some of the guidelines we suggested. And basically they're doing a job. They're doing a good job. And at the moment in Gaza, it seems contained. But as I say, the potential there for a severe outbreak is definitely there.
There's a question whether it's conceivable to send doctors, I don't know if to Gaza, but maybe to the West Bank, or is it not on the table?
I see the question that said, would you consider sending doctors to the West Bank or Gaza to treat patients or train doctors? That's exactly what we're doing, not treating patients. And I don't think they need us to treat their patients at the moment. I don't think they need them. By the way, they haven't seen the severe cases who need respiratory support yet. Happily so. Hopefully it may stay like that. But they also, these are very professional people. I mean, these are people who've been on fellowships, you know, in Western countries and worldwide. They're very capable people, and obviously we're there to help them by advice. I don't think we've reached the point they need us to come and help them physically there.
Apart from the professional report, can you tell us a bit about the personal relationship when you meet people?
You know, it's not a long ongoing relationship, although first of all, you have to realize this didn't start, I mean, collaboration between us and the West Bank and Gaza did not start in Corona. A large percentage of patients in Sheba, in oncology and in other, and pediatric oncology, these are patients from the West Bank and Gaza. And I've worked in other hospitals in Israel, and it's the same thing, and we have connections with doctors. I personally was part of an initiative a few years ago where we sent residents in orthopedic surgery, which is my profession, from Israel and from the West Bank to London to do a joint fellowship, and they live together and work together. So these collaborations exist the whole time. And now I think they're getting a backwind, and I think, and hopefully out of this catastrophe, we might be sowing some some seeds of long-term increased collaboration between us.
Yeah, I don't know if you read David Grossman's column a few days ago. He said maybe the corona crisis will change attitudes, and Arabs and Jews will start asking to say, why are we fighting for so long instead of living with each other in peace?
They asked me at the end of one of the encounters, do I know when this will end? So I said, there's two people who know. One is Moses and the other is Muhammad, but it's a bit difficult to talk to them now. So
There's a question about
and yes, here, I'm with you.
What is your advice for Gaza? I mean, what can they or should they do to prevent a
They're doing
severe
the right
outbreak?
thing. They're trying to impose a severe seclusion of people at home, a home quarantine. Not so simple. No, the compliance isn't always as good as we would like it to have, and they have a problem of compliance. Even though we envision that because of the type of regime there, it's much more strict or whatever, but they do have a compliance problem. But they're doing things right. They have this quarantine. They have quarantines areas in the south and north. They're taking schools and turning them to quarantine areas next to the hospitals in order to protect the hospitals, like we did. So I think the principles are the same, but obviously their ability to put them in practice is not always as large as us. Some of the things we do with telemedicine, we've used telemedicine very widely, aren't applicable in the way we do them. But again, there's a lot of things that we do with very fancy equipment they can do with them with a regular cellular telephone, and I show them how to do this as well. So you can do these things. As I say, the principles are the same if you're working in the Mayo Clinic or in a field hospital in Papua New Guinea. It's the same principles of separating between the infected patients and the non-infected, and the suspected patients and between themselves. There are principles. I won't go into the whole principles of how we do these things, but these principles are true all places. You just have to apply them to your specific situation.
Can I tempt you into sharing with us some of your feeling or thoughts about the way this crisis is managed in Israel?
No.
That's...
Now, first of all, no, listen, now I'll be serious, all right? There are many levels in which this crisis is managed, and that's the way it should be. We are managing it both on the clinical and the organizational level within the hospital and within the treatment. The Ministry of Health is managing it on a completely different level. And sometimes there's a clash between the way they see things and we see things. We do have a very good dialogue with the Ministry of Health, and they listen to us and we listen to them. And I think there is a meeting between. Sometimes there's a clash between, in disaster medicine, you do the best for the most. That's the philosophy of disaster medicine. And the word triage is not a thing you do in everyday life. But we're in a different situation now, and we have to adjust to the situation and work with wisdom and work systematically and try to be in front of the events and not after the events. And that's what we've been doing in Sheba since we started this.
There's a question about a meeting you had with where Sheba and Magen David Adom organized when you shared knowledge with some 100 medical personnel from the West Bank. Can you elaborate on that?
I was not involved in that, so I'm not sure. There might be, Sheba is a big place. There's 9,000 personnel here.
Right.
9,000 staff. So I was not involved in that meeting.
Can you say something about your thoughts about where are we in the process of the plague of the virus? I mean, Are we seeing the beginning of the end of the beginning? What?
I think so. We're waiting for the big wave yet, which may or may not come. We don't know. This virus behaves very, very weirdly. You know, I don't know if you know Shaykh Ophir. I'll turn to Hebrew, but what Shaykh Ophir said, "Avirus ukmo mankrob rak yoter ars."
Oh, the virus is like
Like a germ, but
it's more sleazy,
he's more sleazy. Yes, exactly.
sleazy, something like
Shaykh
this.
Ophir was one of our old comedians. Anyway, may he rest in peace. Um, I don't think I don't think we know. I don't think we are preparing for the possibility of a major surge still. I don't think we can say we're over that yet, but I think we're well prepared for that, both on definitely on the Sheba level and I think on the national level as well. We used to say we want to be like Singapore, not like Italy. Now it's for the first time we say we don't want to be like New York.
Yes.
Talking
Where do
about
we stand? Where do we stand?
talking about management.
Uh, where do we stand compared to other countries?
We stand. Our mortality rates are very low. Our mortality rates are very low. But the incidence in the population is not low. And we are seeing, and as daily, we're seeing more and more complicated, complex patients. So that's why I say I don't think we can say we're over the hill yet.
There's a question going back to the West Bank. How come there are so few cases in the West Bank? Maybe they don't test enough?
Look, the question of numbers definitely depends on the number of tests you take. The positive people, if you don't test, you don't have positive numbers. But what you cannot, so you can say there's few cases, few positive cases because there's no testing. But there's also a few severe cases and few deaths. None, as far as I know, maybe a few. There's a small number of deaths and not a large number of severe cases. And that has, you know, if you did or you did not test, you would see those cases. So again, I don't think they're in a catastrophe like Italy or New York or you know, some of the Spain. I think they're also well contained. Hopefully, it's because they are quarantining people. They are a divided society, as we know. They cannot get easily from place to place. We know that. It's nothing political I'm saying now, but it's a fact. So there is some degree of segregation between groups there. In Gaza, definitely, because they're closed off. So this might be a barrier for penetration of the virus. And that may be the reason.
I have a question about the medical staff at Sheba, your hospital. How they are coping? Share with us a bit their experiences because they're working 24/7 and they also have families. They have parents, maybe.
I think they're coping amazingly. You know, I've been in quite a few disaster situations, and earthquakes, and cyclones, and in volcano eruptions, and I've been in both military and non-military delegations. And one of the things which happens in these situations is that, first of all, you don't hear the word no. It doesn't exist. Usually when we go on missions, we have a problem pushing people off the plane, I mean staff members, because everybody wants to go. And I think what's happening here in a similar way, everybody is really recruited to the cause. We see people really working day and night and not wanting to go home, not because there's something wrong at home, because they feel that they're part of this amazing effort. I think we're seeing an amazing team building. Sheba has an outstanding leadership, which is working both on a very orderly way. You know, a lot of us are ex-military, and that maybe has something to do with that. But on the whole, I think we have resiliency here, both medical and emotional resiliency. Our social work and psychosocial staff are working very hard, both with the patients and with some of the staff when needed, and that's a given. And I think we all realize that we might still be in for very, very significant tests, but I think we all feel that we can pass those tests.
This is very heartwarming to hear these words. We are ready to wrap up, but there's one question about what is the latest analysis of the 20 to 50 age group? Somebody is worried, particularly here, probably.
His 50th birthday is next week. No, it doesn't happen like that. It's not. These are groups. An interesting thing I was discussing with one of my colleagues today is obviously we all know that the higher the age group, the higher the mortality, and that we know. However, we're still trying to see if age as an independent variable has that effect, because obviously the higher the age group, the more comorbidities there are. But if you take somebody who is 70 and has no comorbidities, we're not sure if age as an independent factor is actually the high mortality factor. We don't know this yet, but definitely.
Good news. Good news.
Yeah,
good
yeah.
news.
We know. We know our age, right? Anyway, no, but seriously, there's no question of it that if you're younger, you're less prone, and you're not less prone for getting infected. And in fact, at least in the beginning, we saw a lot of infections among the youngsters because they're wild kids, and they find it harder to stay at home. But there's no question that if you get infected, that the older you are with comorbidities, you're in a higher risk, and the younger you are, it's better. That's true of life in general, isn't it?
It is. So on this happy note, Professor Bar-On, I want to thank you for being with us and for excellent discussion. And thank you all for being with us. I give you a heads up for tomorrow. 11 a.m. we'll have General Giora Island, who will suggest an alternative model for managing the crisis. He's quite provocative about it. And at 1 p.m. we'll have Tzipi Yarom, a Haredi activist, who will address the question of whether in the coronavirus crisis, the Orthodox are a special case. Thank you very much for everybody for being with us. And thank you, Professor, again, for taking the time.
Have a good day. Bye-bye.